Well, good morning, and can I welcome everyone to this, the 32nd meeting of the Public Audit Committee in 2024. Agenda item 1 is for committee members to decide whether or not to take agenda items 3, 4 and 5 this morning in private. Is the committee content to do that?
Agreed.
We are agreed. Thank you very much. And agenda item 2 is consideration of the Auditor General for Scotland's Section 23 report into the NHS in Scotland 2024, which is a finance and performance report. So I'm very pleased to welcome to the committee this morning Stephen Boyle, the Auditor General. Good morning. And the Auditor General is joined this morning by an Audit Director, Carol Calder, Lee Johnson, who's a Senior Manager at Audit Scotland, and by Bernie Milligan, who's an Audit Manager at Audit Scotland. We've got quite a wide range of questions on what is a wide-ranging report this morning, Auditor General. But before we get to those questions, could I invite you to make a short opening statement?
Many thanks, Convener. Good morning, Committee. I am bringing to the Committee this morning a report, as you mentioned, on the NHS in Scotland. It covers the financial and operational performance of the NHS during 2023-24. The report outlines the pressing financial and performance issues the NHS is facing and the urgent need for reform to safeguard health and social care services. I have reported in recent years on the unprecedented challenges that the NHS faces. My 2023 report, which we published in February of this year, stated that significant service transformation is required to ensure the financial sustainability of Scotland's health services. Convener, those issues remain and indeed, based on the evidence in today's report, have become more pressing. Health spending remains the single biggest area of government spending in Scotland, accounting for around 40% of the Scottish budget. 2023-24 saw a real terms increase of 2.5% of health spending, but the sector has faced cost pressures from new pay deals, other inflationary pressures, meaning that boards have still struggled to break even. Many have required additional funding, are forecasting recurring deficits over the medium term and face wider risks to their financial sustainability. Health spending is forecast to continue to grow at a faster rate than other areas of public spending, and last week's draft 25-26 budget set out plans to increase total spending to £21 billion. The NHS in Scotland is still seeing fewer patients than before the COVID pandemic. Most national waiting time standards haven't been met. Commitments to reduce waiting lists are also not met, and there remains pressure across the system with the highest recorded levels of delayed discharges. Accident and emergency waiting times remain considerably higher than they have been and below performance standards. Initiatives that have been put in place to address these issues are not yet having impact on headline indicators. Clearer and more transparent reporting of progress and evaluation of impact is therefore needed to better understand what is working and where the opportunities for change are. Wider reform and a focus on improving the health of Scotland's people is essential. This needs to be part of a clear plan for delivering on the Scottish Government's vision for health and social care. It also means that difficult decisions will need to be made about transforming services and potentially what the NHS stops doing. The Scottish Government has called for a national conversation on how health services can be transformed to meet today's challenges, but we've seen little evidence of progress on that front. Convener, lastly, greater leadership in our view from both the Scottish Government and NHS leaders is needed for the radical decisions about the changes that are required for the longer-term reform to take place. Convener, as ever, my colleagues and I will do our utmost to answer the committee's questions this morning. Thank you.
Thank you very much indeed. Can I just begin with a very minor technical question, which is that you were sat here giving evidence before us in March of this year. So the cycle of your reporting on the National Health Service in Scotland, its financial state and its operational performance, you've changed the date of publication. Does that mean you are now going to revert to an every 12 months and it will be around this time of year that you'll report?
Yeah, exactly. So, Convener, this brings us back to where we were before COVID, of reporting late autumn, early winter of the following in the same calendar year effective as the preceding financial year. So, for clarity, it's not our intention to produce a report every 10 months on the NHS, and our expectation as we finalise our work programme in early 2025 is that we'll be reporting on the NHS towards the end of next year.
Thank you very much for clarifying that. Your report includes a summary of progress against some of your recommendations from previous years' reports. Some of the recommendations you have made in previous years are repeated again this year. I mean, do you think sufficient progress has been made in the areas that you've highlighted as being important to improve the performance of the National Health Service in Scotland?
I don't think we can say definitively that we've seen the progress that is required, Convener. I think that's spelt out throughout today's report, that many of the issues that we have reported on, perhaps not just last year, but a recurring theme of reporting from myself and my predecessor on the need for reform of the NHS. Public service reform more generally hasn't progressed at the pace required. So we think carefully about the merit of repeating a recommendation, but we think because of the issues are so significant and require such focus, is that we have gone back to many of the themes in previous reports. And you'll see from today's report that the need for a clear delivery plan to support reform and transformation, delivering upon the Cabinet Secretary's restated vision for the NHS in the summer, is the central theme. But as I think as you're referring to, Convener, that's not a new recommendation from us, so much is still required to be done that builds upon previous recommendations. Okay, thank you very much. I'm going to invite the Deputy Convener to come in next.
I wasn't expecting to come in so early. Thank you, Convener. Good morning to our guests. I want to look at the bigger picture. Just let's take a top-level approach to this. In your opening statement, Auditor General, you painted quite a stark picture of Scotland's NHS, that despite a 2.5% real terms increase in funding from central government, outcomes and outputs seem to be poorer and in many areas getting worse. Seeing fewer patients, waiting times getting worse, further delayed discharge from hospitals, and of course A&E waiting times, all of which we'll come on to in this session. But I guess the logical question is, how on earth can government be spending more and more money on a public service, but things be getting worse? What are the main drivers of why that is happening, in your opinion? Yeah,
good morning, Deputy Convener. I'll bring colleagues in a moment, actually. Perhaps I think you're referring to, I suppose, is the productivity of the NHS in Scotland, to set out some of the factors that are influencing, I suppose, the headline that is in today's report, is that many of the indicators, and indeed we set these out at Appendix 3 in today's report in a bit of detail, which analyses the government's 9 headline indicators to measure the performance of the NHS. And that analyses that by boards and then by Scotland across the piece, is that we are delivering on 2 of those indicators as a whole that suggest that there's a system under real pressure. So I'll talk about productivity in a minute, but I think one of the things to emphasise is that we saw in the committee very well cited on last week's draft budget that will increase the funding available to the NHS in Scotland to £21 billion, up from just over £19 billion from the current financial year. Much of that will be spent on settling pay awards for people who are working in the NHS. And what we are recommending in today's report is that spending more money, as we do each year. I mean, each year there will always be record levels of investment in health and social care services. What it's not yet translating to is improvements in outcomes, productivity, efficiency. And I think that's why we're kind of core part of today's report, from our perspective, is the recommendation is that we can operationalise the vision with a clear plan, so that people who are working in NHS those charged with their governance and oversight and Parliament and the public's ability to scrutinise can be very clearly track what comes next.
Before you do, can I just pick you up on some of the terminology you're using? There's a lot of audit language in there. You're talking about efficiencies and productivity and management, operational management. What do we? I want to get to the nub of the issues, though. What do you think actually needs to improve? We're talking about pumping more money in, which you seem to suggest is getting sucked into pay awards. Now, I'm not disputing that pay awards are an important part of public expenditure. Indeed, I think nobody around this table would argue against the value that we place on our public service workers, particularly those in the front line. However, it seems to me that simply these year-on-year increases of money going into pay awards is doing nothing to improve outcomes for patients, for the public. So, I mean, when you talk about productivity in the health service, what exactly do you mean? What actually is the government not doing or should be doing to improve outcomes for public health?
So I will bring Carol in a moment, Deputy Convener, but I think perhaps as a headline answer to your question. So the first thing I say is complicated. If this was straightforward and easy, we'd have done it. The NHS, no doubt. People are working incredibly hard under really challenging circumstances, and I would have found a way to recover at least back to pre-pandemic levels, if not looking to better that level of performance, given these are real terms increases in funding that are going into the NHS. Productivity, so we pepper this throughout today's report, and we have seen references, both in the budget and in the strategies and plans on the NHS, that a renewed focus on productivity is what's required. But it becomes complicated when much of what drive productivity will be investment. So investment in infrastructure, investment in new technology. So as referenced in the report, that the planned investment in national treatment centres, given the restrictions through a reduced capital budget, have been paused. We also know that the NHS estate is ageing in Scotland, that patient flow through hospitals remains interrupted compared to pandemic. So, for example, you referred to delayed discharge as being one of the problems. So people are spending longer in hospital, thus interrupting the natural flow of patients arriving, planned, and then planned treatment and exit. So all of these are factors. Whether they are surmountable or not is primarily a question, I think, for NHS leaders to address as to how they are going to tackle, beyond identifying the problem, what then comes next. I'll bring Carol in. I think there's probably a bit more insight that she can offer in terms of productivity, if you're content.
Thank you, Auditor General. So, yeah, as the Auditor General said, it's very difficult to measure, but I suppose in simple terms, it's looking at inputs and outputs. So the outputs would be inpatient and outpatient appointments, procedures, numbers of procedures and day cases. The inputs would be staff, supplies, facilities, spend, equipment. So it's looking at a balance across those things to get a measure of productivity. The Auditor General mentioned the lack of investment in infrastructure as being one of those factors. The IFS produced a report in February looking at hospital productivity that has decreased since the pandemic, and other factors that they'd identified that impact on productivity are workforce factors, which would include sickness absence levels and would include things like vacancies. The increasing complexity of care that patients are requiring, so demand has increased, there are more patients, and the care that they require is more complex, particularly when there's a backlog and people have been waiting a long time for treatment. There's a lack of a shift to improving population health, fundamentally, and shifting spend towards prevention and early intervention. And of course, delayed discharges has an enormous impact on the flow of patients through hospitals, so that impacts on productivity as well. So there are a number of factors that have been identified that influence productivity levels.
Sorry, I'm just audio technician. But that's very helpful, thank you. And I think you've made some of those. We're digging below the headlines a little bit more with some of this. I mean, I guess I get a feeling of déjà vu with this session. I haven't been in the Public Audit Committee that long, but I've been in this Parliament 8 and a bit years now, and there are others around the table who've been here much longer. These are perennial issues in our health service. Auditor General, at what point do you think, you talked a little bit about this so-called national conversation that we need to have about our health service. What should that national conversation look and feel like? You know, the NHS is sacrosanct in politics. It's the sort of thing that few politicians and political parties would want to really tinker with in terms of structural, in terms of how it's funded, where the money comes from, how it's spent. However, health and social care are fully devolved matters, so therefore there is the ability for the Scottish Government to take a direction of travel that it sees fit to make the service fit for purpose and good value for money, which I think is something we all want to see. What would you like to see happen in Scotland? What is this national conversation? What are the sort of difficult things we need to be talking about as politicians, as a society, and as a health service?
Yeah, I think so. As I mentioned in my opening remarks, Deputy Convener, there is much reference to a national conversation, and one that we are supportive that needs to be part of the process. We are looking to see more evidence about what that will actually mean from NHS leaders, from the Scottish Government, about how they intend to structure it. In and of itself, it's important, but we need to move beyond the conversation to, when we talk in many of our reports about the need to bring service users through processes of change, to involve them in the shape and structure of how public services will be delivered. So that absolutely has to be part of the process. In terms of beyond the conversation, though, is that ultimately we will reach a point where we have to translate a vision into a detailed, measurable plan for how we will deliver upon the government stated vision. And that's the Cabinet Secretary restated that to Parliament in June, one of a preventative-based model, population health. And you're right to reference that this session can become quite jargon-heavy, but ultimately it's about keeping people healthy out of hospital for longer, that they lead healthy lives, can manage their treatment, their care closer to home or in a homely setting that doesn't require them to be in hospital. And that will be very much about personal responsibility, lifestyle orientated will be factors of that. Where we choose to site different hospital services, the investment that we make in primary care or GPs and their colleagues relative to hospital settings. Last point I would make, Deputy Convener, and I suspect the committee will want to explore it further, but is that I mentioned opening remarks, and we do make a point in the report about part of that conversation, absolutely led by medical experts and professionals, will be about prioritising and giving consideration to what the NHS does and doesn't do. So, for example, Scotland's clinical strategy still makes reference to the fact that around, and in the view of medical experts, not auditors, that about 20% of medical interventions in Scotland are of low clinical value and don't produce intended outcomes. And that report, that strategy goes back to 2016. What we're looking to see is that to be wrapped up in the plan. And that will be difficult because these will be people's specialisms, their careers, and thinking really carefully about where we're adding most benefit and value to people who use health and social care services. So no doubt part of our conversation, but getting beyond that is really crucial.
I mean, you talk about difficult conversations. Is there an appetite for that? Because we can have a national conversation, which it seems to be, hopefully will produce some sort of government vision, which then will produce some form of plan or strategy, which then will be implemented. All that's going to take a huge amount of time. And it sounds to me, with the health budget running at 40% of the Scottish budget in total and increasing every year on year, we're running out of time. At what point do things become unsustainable? And as part of those difficult conversations, should anything be on or off the table? Are we talking, What sort of things are we talking about here? I mean, for example, there are many difficult conversations already happening, but the problem is politics often gets in the way of some of those. You know, is it fair, for example, Auditor General, that you get free prescription charges? You know, these are the sorts of difficult conversations that perhaps we ought be having as politicians, but we're not.
So I think these are policy decisions that the Parliament, the government, will choose to make about how we spend the Scottish budget. You quite rightly point out that health and social care is a devolved matter, so there is licence for the Scottish Parliament to get into what is undoubtedly potentially difficult territory. I think the driver, I think you allude to, Deputy Convener, is that based on the projections of the Scottish Fiscal Commission, again, talked about in this committee before, that health and social care currently sits at 40% of the Scottish budget. They project that's going to grow, so to over 50% in years, decades down the line, without the level of change and reform. And the risk of stating the obvious, that means less money for other vital public services. So I think for me that is the driver that we would want to both improve today's use of 40% of the Scottish budget, but the risk that if we don't reform, it will consume 45, 50% in years to come, and not necessarily strong evidence that that increased level of spend will reduce better outcomes without a change or reflection on the current arrangements of how we spend that money.
There are lots of questions this morning, and I'll probably come back later, because I do want to have a conversation about preventative healthcare and some of those reforms that you talk about that may, down the line, actually improve outcomes as opposed to just cost more money. But I did want to point your attention to Exhibit 5 of your report, which I found quite interesting when I was trying to dig below the surface of why health boards are running out of money, why so many of them face deficits, why so many of them are borrowing money, is prescribed drug costs and staff costs. And this goes back to my first question around pay increases and what's driving those. Has there been a piece of analysis done within Audit Scotland around what are the main drivers of those? Is it simply percentage pay awards and the increased costs of drugs from pharmaceutical companies, or is there something else that we're missing?
I'll bring Lee in, actually, who's kind of compiled this exhibit and some of the analysis behind it, Deputy Convener. But you're right, I think principally pay awards, and they're not all the same as well. We make reference in the report to the analysis of pay awards, so 5.5% for those NHS colleagues who are on Agenda for Change terms and conditions, I think, and higher for consultants, double digit actually, Liam will have the detail, and for resident doctors as well. I think perhaps just lastly before turning to Lee, we haven't done the detailed analysis on the drivers behind drugs costs and we're referencing in today's report, and that may be an issue that perhaps the committee might want to explore with the Scottish Government, but I'll pass to Lee for anything she wants to add.
Thanks, Auditor General. I think in terms of the pay deals, again, we didn't look at the drivers behind that, but I just wanted to flag, I think it's worth noting, a recent report from the Institute for Fiscal Studies, and it looked at recent trends in public sector pay. Now, just as a caveat, it did use data from both England only, but also across the UK. But it looked at kind of the trend in public sector pay, and I think pre-pandemic there had been lower increases both in nurses and teachers' pay, and that's resulted now in what we've seen recently in those higher pay awards that we've been seeing. And of course, Scotland's NHS staff have secured some of the best pay packages in the UK, and of course we've also been one of the only nations to avoid strike action, I guess, within the NHS. In terms of the prescribed drug costs, as the Auditor General said, we didn't look at that in any detail in terms of what the drivers are in the cost increases. But I think it's worth acknowledging Scotland's increasing burden of disease, increasing numbers of long-term conditions, and obviously our ageing population, and that's obviously impacting on those increasing drugs costs.
Thank you. It's very insightful. Thank you.
Okay, thanks. I'm going to now bring in Graham Simpson, who I think wants to continue some of those themes that the Deputy Convener introduced. Graham.
Yes, thanks very much. The Deputy Convener has helpfully touched on some areas that I was wanting to ask you about. So if I can just go back to this so-called national conversation. You say, you say repeatedly in report after report that we need reform, and you've made that very clear in this report. You touch on this national conversation. Now, I don't know whether that's been going on or not. The Health Secretary announced that there was to be one. I know he spent some time talking to football fans, but I'm not aware of a national conversation around the health service actually starting. Have you seen any evidence of it?
I'll bring Carol in a second just to kind of the detail what we have seen it, but I think perhaps just reference my opening remarks, saying we've seen really limited evidence of what the government's intentions are around the national conversation to move on and deliver its vision. The budget, as I mentioned earlier, Mr Simpson, also makes reference for the need for reform of health and social care services. But I think we're in a place at the moment of looking to see that detail. But Carol can offer any more insight.
Thank you, Auditor General. We don't know what the progress is with that yet. What we would hope, though, that the framing of that conversation is about what needs to change in the NHS and how we all need to change in terms of consumers of the NHS. So it's an honest and realistic conversation about how the NHS needs to reform, rather than a conversation about rehearsing the problem or a conversation that is a wish list. What should the NHS look like? It's what should the NHS look like within the constraints of affordability, long-term affordability and long-term sustainability of the service.
The problem for me is that the phrase national conversation is thrown out by government. It's almost become a new buzz phrase, and it doesn't actually mean anything. Because I'm not clear who the government is meant to be talking to or what this conversation is meant to be about, who with. Have you got any actual clarity on what this phrase actually means in relation to the health service?
I think we've been clear. No, we don't have any additional detail beyond the reference to the commitment to it and how important that this is. But I would perhaps, at the risk of restating one of my answers to the Deputy Convener, I think it can only be an early part of the process, Mr Simpson, in terms of a national conversation. In and of itself, it is not likely to change the performance, the outcome, people's experience of the NHS. That it has to therefore be accompanied by detailed plans, measurable, actioned. Some of the things that we talk about to the committee very regularly, that strategies are operationalised, so that they are reflected in plans. You can see what's actually happening and what the intention is 12 months down the line, 3 years, 5 years, and so on.
So when we talk about reform, we're potentially talking about making choices. And you say one of your recommendations is that the Scottish Government and NHS boards should, ahead of 2025-26, identify between them areas of limited clinical value and actually consider whether they should be delivered more efficiently or indeed withdrawn. Did you have anything in particular in mind? I mean, could you give an example of something that, in your view, is of limited clinical value?
Well, I referenced the committee to paragraph 104 of today's report, and also I'll bring Lee in a moment, actually, just because we want to be really clear in the evidence to support this point. I think the first thing I would say is not for us as auditors to identify which procedures are or aren't of clinical value, but we do reference the government's own strategy. So they themselves, in their clinical strategy from 2016, cite that 20% of medical interventions are of limited clinical value. What that needs to be translated, in our view, is to, well, what in their view is of limited clinical value? If that's not delivering outcomes for patients, not delivering value for money, there needs to be transparency around that, in our view, about, well, why continue with it? And before passing to Lee, I think I would say is that we absolutely recognise that this is really difficult territory. This will be very emotive, challenging for people who work in the NHS. If it's you or your family member who's receiving that level of service, that's going to require lots of careful engagement and discussion, taking it out of the personalisation of the interaction between the medical professional and the patient is done much, much earlier than that. But I think Lee can say more, Mr Simpson, about the positioning of that strategy and the government's intentions around it.
Thank you, Auditor General. Yes, so just to be clear, the National Clinical Strategy that the Auditor General talks about is from 2016, but the government have been very clear that it is still the strategy that is guiding their work as far as the NHS is concerned. But I think the other thing that I would add to that is that we do know that the Scottish Government are working on this in terms of looking at both medicines and procedures that are of low clinical value. So in terms of para 44 within the report, where we talk about a 15-box savings grid that boards have been working with, that the Scottish Government have circulated, two of the boxes within that grid. One of them is about medicines of low clinical value and procedures of low clinical value. I guess what we would like to see is just further progress. We know that they're still working on that. They haven't yet identified what those medicines and procedures are to boards. So we would just like to see greater progress, but we do know that they are working on it to try and circulate which medicines and procedures should be of lower priority for funding or, as we've already suggested, stopped altogether.
So if the Scottish Government are saying that 1 in 5 of the things that, let's express it this way, the things that happen in the NHS is of limited clinical value, whatever that means, do you think it's up to them to tell us what they mean by that? Spell it out.
I think, so guided by the experts, I think is probably what I would frame it as, Mr Simpson, that if not them, then who, I suppose, would be my question back to you, if you forgive me for that. But I think it has to be preceded by full engagement, with those that work in the NHS, the medical experts, and then engagement with the public. If we are getting down to that level of detail, I think for us it's maybe just to segue ever so slightly. I don't think this is the only way that NHS reform will be delivered. I think it has to be accompanied by the productivity analysis that Deputy Convener was touching on. How are we using the estate? How are we supporting patient flow? Attendance, turnover levels within the NHS all has to be part of that detailed delivery plan that translates the vision, and we move beyond the diagnosis of the challenges of the NHS to where do we actually want to get to in the years to come.
Okay. If I can turn to the issue of boards being given brokerage loans, we could say that boards have been bailed out. They've used that phrase before. And you say that in 2022-23, 5 boards needed that extra money from the government to break even. In 23-24, that increased to 8 boards. I suppose my initial question would be, why, in your view, have things got worse?
So you're right. Lee can talk to this point, actually. I've looked in a bit of detail, not just for the compilation of today's report, but also the analysis that we do to build on the evidence for today's report from the work that auditors have done across the country, looking at different boards. So you're right, there is a picture, and we set out the detail at Exhibit 6 in today's report, is of increasing financial pressure on individual health boards. And the committee will be familiar with the NHS Scotland escalation or support and intervention framework and the various escalation levels for that. What it looks, at a glance, suggests that for those boards that are at level 3, almost all of them required financial support by way of brokerage. And then similarly for a handful of those at stage 2. Before passing to Lee, Mr Simpson, about kind of the detail behind that, I think it is worth noting that the government is, on the back of the draft budget, is in the process of changing its brokerage arrangements. So they have communicated with health boards over the last week or so, signalling a change of plan for brokerage in future years. We wait and see how that unfolds over the rest of this financial year. But the presence of brokerage in 25-26 might not be as significant as it has been in previous years. And we can say more of that in a moment, as you wish. But I'll bring Lee in first of all.
Thank you, Auditor General. I think, obviously more boards have sought brokerage this year, and I think it is a combination of factors. I think both the fact that many boards rely on non-recurring savings, therefore they're carrying forward deficits from the previous year into the next year, as well as a combination of cost pressures. And I think boards who required brokerage identified a range of cost pressures, including the prescribing costs that we've just talked about, pay costs and overspending in specific service areas, for example, in the acute service and also services delivered by integration joint boards, as well as agency staff costs. So it's a combination of factors that feed into that, the pressures that the boards are facing.
Well, actually, looking through Exhibit 6, and in the column which is entitled Primary Factor for Escalation, I see mental health performance coming up time and time again. So that would appear to be a factor in a lot of boards, that big spending on mental health services, which is perhaps pushing them over budget.
I think it's a factor. I'm not sure there's a direct correlation between spending on mental health services and being the trigger specifically for brokerage requirements. The escalation factor can also be about the quality and breadth of service. But inevitably, the provision of that important service will be, part of the reasons why.
Are you able to say any more about what you've mentioned just a few minutes ago about this change of procedure?
So I think this refers to correspondence to chief executives of NHS boards from the Director of Finance of the NHS in Scotland, indicating in light of the increase in funding to boards following the draft budget, and assuming that passes through Parliament for 25-26, that brokerage won't be available during 2025-26. The committee will be familiar with some of the historic brokerage arrangements whereby there's been a couple of iterations where previous balances that were owed were written off at the end of last decade, and then there were no brokerage arrangements during the pandemic. So the government's approach to brokerage has fluctuated from time to time, but I think the indications are that in light of the uplift to NHS funding, it's the government's intention that no brokerage will be required. If I offer a view on that, if it's helpful, I don't think that's necessarily unhelpful, because I think it actually signals to boards that to manage within the allocation that they have received, and I suppose gives a parity to funding of individual boards across Scotland.
Well, yeah, but presumably every single board would try to come in within budget, but the reason they ask for more money is that they don't achieve that. So it's all very well the government saying, sorry lads, there's no brokerage this year, but inevitably some boards will not hit the budget, and they'll come to the government asking for more money. So what happens then?
So I think two things I would say on that is that I suppose also exploring the incentive or disincentive if brokerage becomes available. And we've set out, both in today's report, and Lee can say a bit more about savings that have been achieved. They're not all achieved on a consistent basis. So some boards consistently manage to meet their savings target and break even. And I wouldn't want to understate the complexity of this, Mr Simpson. So there'll be a range of factors, and indeed there'll be varying views about the appropriateness of the baseline funding, you know, the NRAC or National Resource Allocation funding model, about whether that's a fair starting point. But if brokerage is or isn't available, boards still have a requirement to meet their performance, their financial target, to break even. And in the event that they don't, the auditors of that board will have to consider what that means in terms of their opinion, and then that will come to me to think about any statutory reporting.
I mean, you mentioned, I think you say this may be superseded now, that the government was saying to boards there is a cap. We're going to have this cap, I think it was 3%. But that's now been overtaken by the government saying there's not going to be anything, don't bother asking.
Two different things. I think, if I understand rightly, and Lee can keep us right on this, that there's a 3% savings target for boards to deliver each year. I should say that for the territorial boards. The national boards had a higher 5%, if I'm right, in terms of savings targets. Brokerage still remains for the current financial year, 24-25, but as I say, the government's indications are that that will not be available in light of the higher funding allocations as a result of the proposals in the draft budget. But I'll bring Lee in if there's anything she wants to add on that.
Just to, so overall, there was an NHS-wide target of 3% of recurring savings that all boards were asked to achieve in 23-24. Now, they did achieve, I think it was about 3.3%, but they were not all recurring. That was a mix of both recurring and non-recurring. And then laterally, national boards were asked to make a further 5% saving on top of that in terms of further savings.
Okay, thanks for that. I have a feeling we'll be coming back to this, whatever the government says. I'll leave it there.
Okay, thank you very much, Graham. I'm now going to invite Colin Beattie to continue this theme around financial performance with some questions on that. Colin.
Thank you, Convener. I'd like to start with IJBs, which have been a favourite source of our conversation in the past. Paragraph 22 highlights that financial transfers are made regularly from Scottish Government's health and social care portfolio budget to the local government portfolio budget. And in 23-24, that amounted to nearly £1 billion, which is increased from £878 million in 22-23. NHS boards also allocated a significant portion of their budgets to integration authorities, and I believe that was about £7.6 billion. Now, the report also says that during the pandemic, IGB's built up some significant reserves of about 300 million, but they were used mostly in 22-23. So the financial position of IGBs is having a pretty significant impact on the financial position of NHS boards, with a number of them having to fund the IGB overspending. Now, I know, for example, in my own area, that health and social care is running way over budget by multiples in terms of their provision of care locally. So, coming to the question, the report states that the financial transfers around £1 billion were made from the government's health and social care portfolio to local government, and the allocation of £7.6 billion to the integration authorities by NHS boards. What's your assessment of the financial strain on NHS boards due to overspending of IJBs, and what needs to change to improve the financial management and accountability of IJBs?
Morning, Mr. Beattie. I'll turn to Carol in a moment, actually, because I think as the committee will be able to hear, I suppose, Carol's insight from working some of our audit of local government activity, supporting the Accounts Commission, who have reported, as we reference in today's report, on the financial pressure that Scotland's IJBs are facing, and they set that out earlier this year. I suppose before turning to the financial consequences for NHS boards as a result of IJBs, I might just provide a little bit of detail. The number you reference at paragraph 23 on the £7.6 billion transfer to integration authorities. That's largely the funding that Scotland provides to primary care services. In Scotland, the independent contractors are GPs, pharmacists, opticians and others to support the delivery of their services. The model that we have in terms of the financial transfers to IJBs talks about the financial circumstances of that pressure. One of the drivers behind that pressure is the increase in budget is the commitment to pay real living wage to workers in social care sector. But I think there's no doubt that what we're seeing, and certainly the Accounts Commission has reported widely on the financial pressure that IGBs are facing. The detail behind that, I can bring Carol in to say a bit more for the committee.
Thank you, Auditor General. So in the last couple of years, we've done a financial overview of IJBs, but as they're local authority bodies, that's been reported through the Accounts Commission. Next year, we will be looking at a joint report looking at IJBs within the context of social care, so that covers health and local government. So it will be a joint report with the Auditor General. So as the report mentions at paragraph 23, there was a significant amount of reserves built up in IJBs over the COVID pandemic, and a lot of that money was also from underspend on staffing. So difficulties in staffing level in IJBs. Those reserves have been diminished now, and so we're at a bit of a turning point where some IJBs are struggling financially, and we'll be reporting. We're just looking at the accounts actually, and we'll be putting a report out in the spring to cover that the IJBs just now to the Accounts Commission. But the financial position of IJBs has worsened, and that will have an impact both on local government and on health, who have to fund the IJBs as well. So it's something that we have an eye on, and as I say, we'll be reporting on it as a system through a joint report through the Auditor General and the Accounts Commission next year.
So what needs to change? I mean, they're putting financial strain on the NHS boards. What needs to change to improve the financial management and accountability? And accountability is an important thing here that I think we've been concerned about in the past.
So I think we come back to the issue of reform and sustainable services. So IJBs are providing health and social care for adults, and some are providing them for children as well. There is an enormous strain on that part of the system, as we all know. That contributes to the financial pressures in IJBs. We audit them, Audit Scotland, and through our mixed model approach, some of the private audit firms audit all the IJBs in Scotland to look at the financial management, financial sustainability. So we report on those separately, and the issues will be different in different integration authorities. But our report next year will be able to answer your question more fully as we look at the system and the impact it has on both local government and on the health system, and we will be raising those issues about what does need to change in financial management in individual IJBs or integration authorities.
Do you have an approximate timing on that report?
From memory, I think it's April, but I will
sooner than I
correct
thought.
myself if that. I'll check, and if that's wrong, I will correct that.
I think the thing I would add to Carol's point is that I guess firstly, as ever, it's not a straightforward answer to this. You know, there are huge demand pressures upon health and social care services, and particularly referencing social care. The demand is driving both, I suppose, some of the system-wide implications that we're seeing. So, you know, in today's report on delayed discharges, the ability for people to, you know, find a safe route out of hospital, you know, appropriate care packages and so forth. Staffing pressures that exist within that sector, notwithstanding the commitments to real living wage, will all be part of the consequence of some of the financial pressures. The changing demographics that we're seeing too in Scotland will be part of that factor. The system, as exists, has been in place now for 15 years or so, if not longer. And I recognise the committee's interest in integration authorities, health and social care models. I think really just kind of echoing Carol's point is that both the Accounts Commission and I recognise that it feels appropriate for us to come together now to look at how this model is operating. What we think will be perhaps and something we'll flesh out in a bit more detail as we settle on our work programme and then consult with the committee early next year on, is particularly looking at delayed discharges and how that process is operating and what implications that's having both for the NHS but also for the integration authorities too.
A great deal more around this, but if there's a report coming in April which will give us much more detail on this, then I'm content to leave it at that for the moment. Just moving on slightly, we touched briefly on non-recurrent savings, which is something we've discussed in committee before. Looking at the current situation, the reliance on non-recurring savings is very substantial, because it's 63% of the savings occurred or achieved recently were non-recurring. That's been a constant worry, and we've not really seen a reduction in the proportion of non-recurring charges. Now, out of the 471.4 million in savings in 23-24, 63% of the savings non-recovering. That's a lot of money. In your view, what's the long-term implications of this reliance on one-off savings, and how does the continued use of non-recurring savings impact on the ability of the boards to adequately forecast deficits in their 3-year financial plans?
So I agree with your assessment that non-recurring savings have been a recurring theme and positioning of NHS boards' approach to breaking even. And at the risk of stating the obvious, non-recurring savings help in the year in question, but you're back to square one at the start of the following year, because what they are is typically is a vacancy management approach about timing of filling vacancies. So you'll have a small saving, but as soon as you fill that vacancy, it's not available. The use of accounting approaches to annual leave balances is another part of it, or procurement savings. So these are one-off approaches. What they're not, compared to recurring saving, is a new fixed approach, a recurring approach to service models. So if NHS continues to remain reliant upon non-recurring savings, and then if we Lee can say more about this, if we layer in what appears to be the government's change approach in 25-26 to brokerage, you risk increasing financial pressure on individual boards' ability to break even. If they don't find a way, supported by the work of NHS Scotland, the Financial Delivery Unit, revised approaches of more individual pressures on health boards. I think that would be my assessment, but Lee can develop on that as she wishes.
Thank you, Auditor General. I don't have a great deal to add. I guess in terms of the recurring savings, I guess a lot of the low-hanging fruit, the easy wins, have already been achieved. So it gets more difficult as time goes on to find those recurring savings. But again, I refer back to the 15 box savings grid that the Scottish Government have shared and in fact agreed with chief executives, and that is very much focused on different areas where boards can start to increase their recurring savings. So as we've said, we've already talked about the procedures and medicines of low clinical value, but also things like nursing agency reduction, which we've seen progress towards that this year, but further progress there, as well as we've talked about productivity, but increasing productivity as well can help make some savings in terms of theatre optimisation and kind of remote outpatient appointments, that type of thing. So they are working very hard to find ways to increase boards' ability to achieve recurring savings.
Would it be correct to say that unless recurring savings are found in reasonably substantial percentages, in fact, the non-recurring side will become larger and larger as a percentage?
I think so. The only caveat I would make is that the additional funding set out in the draft budget might make a difference. So it might make a difference in the short term. However, you balance against that the forecasts of increase in demand, changing demographics, again referencing the Scottish Fiscal Commission's projections about the call on health and social care services, that is likely to squeeze out quite quickly the growth in the 25-26 health budget. So without reform, that clear delivery plan that we talk about, operationalising the vision of moving to a preventative model of health and social care services, it would assume that the reliance upon non-recurring savings will become ever more so.
I think worryingly, your report also says that boards are forecasting recurring deficits, even when ambitious savings targets are being met. What more can be done about that? I mean, you've touched on aspects of it there, but it seems that something drastic needs to be done.
I think that's really where we've reached, Mr. Beattie, that not to repeat my previous answer about the change in the budget, but I think at the heart of today's report is that there needs to be clear, detailed plan for reform so that health and social care services can be sustainable and affordable, that the vision for health and social care services is absolutely translated into a measurable plan that the public, the Parliament, can track and can scrutinise. Otherwise, I don't think it's clear yet as to how we will be able, as users of health and social care services, to move beyond some of the detail and the metrics of a system, health system, that is not yet back to where it was before the pandemic, with indicators suggesting a system that's under real strain.
Just moving on slightly to staffing costs. Your paragraph 35 says that staff costs account for almost 60% of annual NHS costs, which in a way is not surprising because, it is a people industry, if you like. You need the people to provide the service. The people are the service. However, I do also note that in paragraph 38, just referring back to what we were talking about, health and social care, there's £116 million of savings expected from health and social care to meet some of the additional costs that are coming with pay increases and so forth, which seems odd.
So there's a fair amount in that, actually, and I might turn to Bernie, actually, if she might want to say a bit more about, I suppose, intuitively you're right. I think we'd all recognise that provision of health and social care services, is intensely people-driven service. Notwithstanding the investment in new equipment and so forth, that's probably how we would expect health services to be delivered. We do, I suppose, explore not just the financial pressures which we can come back to, but also one of the drivers around how that investment's being used. Staff numbers have increased in the NHS over the past 12 months, and we go on to explore some of the factors that, again, connect back to productivity, about turnover rates, staff absence, and how that's performing as well. So I will pause and bring Lee in, actually, and if you want to add anything, Bernie, please do so.
I don't have much to add other than, obviously, the pay increases in certain respects were higher than anticipated, budgeted for. Therefore, that's, in terms of the money that then needed to be found to fund them. And the 116 million of savings that was announced was part of that.
Okay. You've highlighted the substantial increases in staff costs and the reliance on efficiency savings to meet pay commitments. But how confident are you actually that the NHS boards can achieve these efficiency savings without services being impacted? So
I think what we're setting out in today's report is the need for change. So you can frame that in a way of services being impacted, or on the other side of the coin, services being reformed. So I think our report is looking for that level of change, talking about the need to explore really clearly the prioritisation of spending in the NHS so that it delivers the intended outcomes. Otherwise, it will be likely remaining in the case that there will be record levels of investment in the NHS, but not translating into improved outcomes, shorter waiting times, fewer people on waiting lists. And this is what we're recommending for the government and the NHS to do, Mr Beattie, is to take stock of what will be in 25-26 will be £21 billion of investment, of how that will deliver the intended outcomes that we're not yet meeting through their targets. So how we deploy staff, what savings we want to make, what boards are being asked to deliver in terms of savings is all part of that thinking and the recommendations in today's report.
But we touched on previously about we're at the bottom of the barrel almost for savings, efficiency savings. I mean, I can't remember when efficiency savings started, but it must have been 20 years ago anyway. And every year, NHS boards and so on are expected to save another 3%, 5%, whatever the figure is for that particular year. But there must come a point where there's just nothing left. Without a complete overhaul of the NHS, there must be a limit within the present system as to how far you can go now.
I think that's fair. I think Lee mentioned earlier that much of the low-hanging fruit has been plucked. So, to continue to go back year after year with recurring savings, and I think the evidence in Exhibit 3 suggests that of a ratio of 63% to 37% is recurring savings aren't the dominant feature. So it's about delivering an in-year financial target rather than service change, and service change to translate into delivering better outcomes for people. So there feels a disconnect between how we're spending investment in the NHS and what we're actually achieving. Savings is a part of that, but I think it has to be supported by a detailed plan, that translation of the vision, so that moving out of this cycle of recurring and non-recurring savings into one of how we're going to move to actually a preventative model and where we spend money that delivers those outcomes.
Still sticking on the theme of staff expenditure, agency staff, obviously the figure for utilising agency staff has dropped. I see in real terms you're saying the spending fell by almost 50 million, 12%. Now, your report says, yes, spending on agency staffs decreased last year, but it's still very much higher than 5 years ago, which I guess is taking it back pre-COVID. So it's still 45% higher than then. But it's a significant cost. I mean, it's still £358 million. What more can they do to decrease reliance on agency staff? Because obviously they're much more expensive than full-time staff.
Yeah, all you say is true. Just referencing, I think, paragraph 89 in today's report just kind of builds on that a bit further, some of the detail that we are still 45% higher in the use of agency staff than we were 5 years ago, in spite of recognising equally that there's 12% reduction from the previous years. The report references that boards have made more use of their nursing bank staff come at, I suppose, two benefits. One is typically a lower rate of pay than agency staff. And bank staff also tend to be known to the NHS board, be familiar with the workings of individual hospitals, rather than having an agency worker who may be at one hospital one day and another the next. So it's those types of approaches that we've seen from NHS boards. I'll bring colleagues in if they can say a bit more detail behind any specifics of approaches that boards have used.
Just to say, I guess there's a range of factors that need to be thought about in terms of reducing that reliance. So further reductions, for example, in sickness absence, turnover rates, and the number of unfilled vacancies could further reduce the number of agency staff required to provide that temporary cover, as well as you've already mentioned, we've already talked about increased use of the board's own bank staff. But again, I keep going back to it is one of the key areas of focus in terms of savings for NHS boards, in terms of nurse agency reduction. And there has been a group formed to address the reliance on nurse agency staff and drive forward a more sustainable workforce model. The group's chaired by the Scottish Government's Interim Chief Nursing Officer and NHS Grampian's Interim Chief Executive. And they're just trying to implement, I guess, a series of kind of phased control measures. So it's about grip and control on your staffing and your use of agency staff to further reduce that reliance.
And finally, just a quick look at vacancies and absences, staff turnover. Now, staff turnover rates have fallen quite substantially, actually, to 6.6%. But the reliance on agency and bank staff suggests there are capacity problems there. How confident are you that the Scottish Government's action plan to improve the well-being and working culture across the health and social care workforce will get the desired result?
I want to offer a view on the work the government's doing in terms of culture. I think it's an important step that the government is taking, to recognise that the connection between well-being, sickness absence, turnover levels, and let's not forget that this is an extremely pressurised environment to be working in. So the level of support that NHS staff have will be a driver as to whether they feel safe and supported, continue to turn up at their work each day. So you have your position on that, Lee. I think it's probably as much a question for us as it might be for the Scottish Government about the impact that they anticipate that this will have to support the importance of the individual NHS employee, but it does have wider implications in terms of productivity, so that days lost in terms of sickness absence or turnover levels will also be a factor in the system's ability to tackle waiting times and backlogs and so forth. But Lee.
Thanks, Auditor General. I guess just to say, Mr Beattie, is we've seen the vision that the Scottish Government have in terms of staff well-being and culture. And obviously over recent years we have reported on a number of initiatives that the NHS has implemented to try and look after staff well-being, particularly following the pandemic. But what we are awaiting on is they've said that they are going to deliver an action plan on how they will deliver that workforce vision, and we've yet to see that action plan, so I can't offer any commentary on how confident I am in that action plan until I see that.
I guess the other thing is that sickness absence rates are quite high at 6.2%, national average 4%. Is it very simply because people in the NHS work in an environment with sick people? And, is it as simple as that?
I don't know if there's a simple answer to that. I think that, so that will be a factor, but so will, environmental pressures. If there's turnover, there's other absence about people's ability to function in highly pressurised environments will all be a factor to that. I think what we're observing in today's report is remained largely the same as it was in previous years, but higher than the government's target of 4%. Sickness absence, as I mentioned a moment or two ago, will be a factor in driving productivity. So if there's a key member of staff, and there will be key people in every hospital, a theatre team, for example, if somebody's not available, that can lead to disruption and interruption in the flow of services and patients throughout the hospital. So I think what really looking for government to answer NHS leaders about what their plans are to drive down sickness absence to the government's target and below.
I suppose I'm very conscious that, as with a lot of the statistics and so on that we get, we're comparing ourselves against ourselves. How do we compare with other health services, say in the UK?
So it's complicated. I think there's been, some much commentary over the past few days, and Carol mentioned the IFS report of earlier this year. But the analysis would appear to suggest that people in Scotland are waiting longer for treatment, waiting longer, particularly for those longer waits over 2 years. There's kind of low five-figure waits of people waiting for more than 2 years for treatment in Scotland, compared to what's reported as a few hundred people across England waiting it. And there will be a range of factors behind that, how the money is spent, the allocation of capital services, the use of the private sector will be a feature of that too, Mr Beattie. But I think the evidence suggests that NHS in England has made more progress in tackling waiting times and recovering to pre-pandemic levels than we've yet seen for the NHS in Scotland.
And things like absences?
So I don't know if I have the detail now. I'll just turn to colleagues if we have that. I think that's something we may need to either refer the committee to NHS leaders, or if we have that more detail, we can come back to you in writing.
Thank you, Convener.
Thank you. And Auditor General, can I thank you for resisting the temptation which has been put your way several times by members of the committee to offer clinical judgments. I really don't think that's fair to ask you to make those. One area that you are, I think, more comfortable in talking about and qualified to talk about is highlighted in paragraph 100 of today's report. And that is a recent summary by the Chief Medical Officer, who talks about the need to focus on equity, prevention and early intervention. And I recall that in the report we considered evidence on last week into fiscal sustainability and reform in Scotland. You once again used as a touchstone the Christie report, which you said had remarkable longevity and ongoing relevance. So these themes are captured in the Chief Medical Officer's assessment too, aren't they? I just wonder whether we've spoken a lot this morning in the first hour or so about reforms to the NHS, but actually there's a wider palette of reform, perhaps social and even economic, that we might need to take a look at if we're going to see a shift in the provision of health services and how we best improve public health in Scotland.
Yeah, I think that's a very fair summary, Convener, and the Chief Medical Officer's report, I think, echoes ambitions and intentions from NHS leaders and the government, and quite reasonably a thread back to the Christie Commission report of over 10 years ago that better outcomes or more affordable levels will be achieved through earlier intervention, preventative-based approaches, rather than a resource heavy focus on secondary care and treating people when they have become unwell. Again, perhaps echoing evidence that I've given to this committee before, is that it's really looking to see and moving beyond that diagnosis into a clear plan. So I think even for the last week's draft budget report, for example, makes reference to public service reform, again, focusing on improving population health, prevention, early intervention, and that will be accompanied by a desire to improve quality, access, and tackling productivity. Very clear, that intention, but operationalising that is what we're making recommendations in today's report, Convener. What a clear delivery plan to support that intention.
Yeah, and let me pick that theme up with, again, something you referred last week, again, in giving evidence to us about your concern, which I think had also been expressed by the Institute for Fiscal Studies and other bodies, about there being a lack of a medium-term financial strategy. And when we read the report this week, you refer to there being insufficient clarity about a medium-term financial plan for the NHS. You also say there we are still awaiting an NHS capital investment and asset management strategy. So there are some quite important parts of the framework here which don't exist. And again, I think, to go back to my earlier point, are calls you've made in previous reports that still don't appear to have been met.
Yeah, these are vital components of the ability for those that are leading the NHS and making some of these challenging decisions over the medium term, Parliament's ability to understand the public similarly about how services will be delivered in the years to come. We understand that it's the government's intention that these will be published and prepared into the spring of next year. And that's going to be really important, because I think together with intentions over the course of the recommendation in today's report over next year is to settle on a delivery plan to translate the vision, and of course the capital and the financial plan will really underpin that progress.
Yeah. One area of capital spending which has come under scrutiny at this committee before is the programme of investment in national treatment centres. And I think when we had the Chief Executive of the NHS before us in June of this year, we asked her about that, and I think she'd sent us correspondence in which she confirmed that the plan had gone from, I think, originally 6 national treatment centres at a cost of £200 million to more than that. But the running total at that time, and this is in the summer of this year, was, I think, £827 million. So a quadrupling of the cost. Can you give it? Are you in a position to give us an update on where we are with the National Treatment Centres investment programme?
So I think, as we set out in today's report, I don't think I have an update. Firstly, on the detail that the Chief Exec shared with the committee in the summer. I think it's been well covered, Convener, that there are the factors behind that relate to the significant pressure that the Scotland's capital budget is under. That has led to prioritisation of national treatment centres. We can pretty clearly see the implications that has for delivering what was the government's NHS recovery plan to tackle waiting times and backlogs. The only thing I would maybe add is that I think, and potentially significant, again referencing, if I may, the draft budget from last week, is that there is capital commitments included within that in terms of a replacement for Monklands Hospital in Airdrie, the Belford Hospital in Fort William, and the Pavilion in NHS Lothian. So what I think we're not yet clear, having not seen until probably next spring, summer of next year, is for those capital plans. What does that mean in terms of timing, cost, but most importantly, what does it mean in terms of patient experience and waiting times?
I think that's right, and I think that was a significant part of the budget announcement last week. Can I just move on to another area? And I'm looking at Exhibit 7 in the report that we're considering today, Auditor General, and that's a bar chart which shows the annual unitary charges payable under public-private partnership. I must say, I was quite surprised that that stretches all the way to 2045-46. In other words, I thought that we'd moved away from this model of private finance initiative, public-private partnership, into a new age where these big unitary costs were no longer, we were no longer liable for them. But actually, it looks like they are ongoing. And, you know, keep me right on this, but the normal lifetime of a PFI PPP is about, what, 25 years, 30 years perhaps. And so we're seeing capital projects under this form of financing that were commissioned, if the expiry date is 2045, were presumably commissioned fairly recently.
So you're right, I will belatedly bring Bernie in to talk about some of this detail. So you're right, we do set out Exhibit 7. I suppose the movement over time, going back from the late 90s and forecasting into mid-2040s, about the cost of the use of private finance to the NHS in Scotland, it is significant and it remains significant. So the headline from the Exhibit 7 is that the NHS in Scotland will make, or anticipates to make, a further £5.8 billion of payments in respect of PFI, PPP contracts. You're also right, Convener, that I think typically these were from a duration of 25 to 30 years. I won't say everything probably Bernie's likely to cover, but perhaps draw the committee's attention to case study 1 that follows the exhibit that sets out, particularly for some of those earlier contracts, there's a range of different arrangements as to what happens at the end. So notwithstanding the significant amounts that are still to be paid, it's not a clear case of there's a model to follow as to what happens at the end of the 25 or 30 year period in terms of the asset returning to the NHS at no cost. Some will be with a cost. So there's a process of management that needs to be put around this. And I think what we've seen from the NHS is working with NSS and the Scottish Futures Trust, so they've got the level of expertise to manage what happens at the end of a PFI contract. But I'll bring Bernie in, and I'm sure she'll want to say a bit more than that.
Yeah, so I don't have the detail in terms of those more recent contracts, and that could be, explaining that kind of push through into the 2040s. I think the main point that we're looking to make in the report through this exhibit is that quite a number of those PPP contracts are now coming to an end, and there's a small number that have already came to an end, but it's really the case study really shows that between now and 2030 it's a really imminent kind of issue for boards. And that really means that, and it can have a knock-on effect in terms of ongoing capital budgets, revenue budgets, what that will mean once those assets become, obviously come back into kind of public ownership and so on. And the main thing is that there's very complex kind of negotiations that have to take place between then and now. Some of them are already taking place, and boards are receiving support from National Services Scotland and the Scottish Futures Trust around that. And it's really important that there is kind of learning through that, how those closure arrangements take place, so that we can understand what that will mean for the future capital and revenue budgets associated with taking those assets back in-house.
Okay. I've got a few more questions on that, but I'm conscious of the time. And so I'm going to invite James Dornan, who joins us on a video link this morning, to put some questions to you. James, over to you.
Thank you, Convener, and good morning, Auditor General and colleagues. In your NHS in Scotland 2023 report, you recommend that the Scottish Government confirm which indicators will be used to measure year-on-year reductions in waiting time, but this year's report states that this has not been done. Can you explain why transparency is so important in assessing progress and planning future activity, and whether the Scottish Government has made any progress in implementing this recommendation and what the barriers are in doing so?
Good morning, Mr Dornan. So you're right, and again, maybe highlight to the committee at Appendix 2 of today's report, where we just track the recommendations from last year's report. I'll bring colleagues in just to kind of share with the committee some of the engagement that we had with government and what we look to assess by way of progress. But I'll maybe address your earlier point first of all about transparency. And I think perhaps, so clearly we think transparency matters, that both the Parliament and the public have a clear say and a clear idea of progress of public investment in health and social care services. I've spoken already this morning about not just a national conversation about the provision of service to support public service reform and to make real through the next stages about the vision for the NHS, what it actually means in terms of a preventative model, where will people access services, how will we as a country help people to stay healthier for longer outside of a hospital setting. So we make more recommendations through over the course of 2025 as that the NHS and the Scottish Government make progress on that front. In terms of the indicators, I'll bring Bernie in just to say about what we've seen so far. Bernie.
Yes, so in terms of the indicators, there is no update. There's no, we've not had any progress reported to us by Scottish Government on developing those indicators. Obviously, they relate to the waiting list, the targets that were originally set in July 22 around eradicating the long waits of over a year, 18 months and 2 years, that were then recommitted in 2023. And as of last week in the budget, there was a kind of commitment around eradicating the waits of over a year by March 26. So there's been no kind of update on that. We do know that the last report, update report on the recovery plan was published in December 23. Now we're expecting, we've had it confirmed that there will be an update on the recovery plan before Christmas, so very, very imminent. And whether that will contain any update on those indicators, we'll wait and see.
Well, that would be helpful if it does come out. We note from your report that unless the NHS in Scotland increases hospital activity and transforms services to focus on prevention and care close to home, it is likely that waiting lists and waiting times will continue to grow. Now, that's already been discussed to some extent, but in your view, what more could the Scottish Government do now to try to address this, other than, for example, the £200 million that they've committed to in the budget?
So, yeah, I was going to mention that, Mr Dornan, actually, about the £200 million to reduce waiting lists and to support reduction in delayed discharges as well. So I think it's looking to see what the detail of that is. I think the risk, talked about to a degree this morning and set out in the report, is we are continuing to have record levels of investment in the NHS, as we've seen, up to £21 billion planned for 25-26. What it's not yet translating to is a significant change in activity, and therefore reduced waits. So inevitably, it feels Funding will be one part of that, but productivity absolutely has to. And I don't think we know yet from what it means from the additional funding that's planned together with the increase of the baseline, as of whether that will make a difference. Probably a risk of repeating goes back to, I think, the point we made a few times this morning, is looking to see that in a detailed plan with metrics to be reported and progress measured against that.
Can I just clarify what exactly you mean by productivity in the NHS?
I think this really, Carol touched, I think, on this earlier, is the volume of activity that happens in the NHS, the number of operations, the number of interactions that, if I can reference to the committee, forgive me one moment, just get the exhibit that kind of sets out activity levels. Thank you. Exhibit 9 in today's report sets out the activity levels thank you, and the weights. And what that references is to the year to June 2019 relative to June 23 and then June 24. So productivity, and there are various factors in terms of staffing levels, staffing absence levels, investment in technology, maintenance of buildings, all of which weave a slightly complex web about the factors that will drive that. Ultimately, this is for the NHS and the Scottish Government to determine how they plan to improve activity, looking at delayed discharges, patient flow. So there are multiple drivers, Mr Donnan, about productivity levels. But at a base level, it's about doing more than we're currently seeing in the system at the moment.
Okay. Some of the changes that are in the process of being made or have been made recently, would you expect that to take a bit of time before you see the impact that you would hope to see from it? And is there anything particular that you have suggested to the government that they should be taking forward?
I mean, much of this will be policy decisions about, kind of where to prioritise and where to spend resources. I think, as the convener referenced, investment in capital was identified through the National Treatment Centres as being one of the main drivers to tackle NHS recovery from COVID and to increase activity. So the publication of the capital programme in the spring of next year, I think, will be vitally important. A real sense of where some of that additional capital that's referenced in the budget, what difference that will make.
Because if the infrastructure budget hadn't been cut so drastically, then the potential for the National Treatment Centres to be up and running and help to lower waiting time lists would have been in place, and hopefully would have had a positive impact. But we are where we are, I suppose. Okay, I'd just like to ask you about the positive changes made by NHS, Forth Valley and Tayside in their performances against national waiting times for child and adolescent mental health services. Do you have any further information on how these changes came about, and if the Scottish Government has mechanisms in place to ensure best practice can be shared across all boards to meet the aim of clearing backlogs by December 2025?
Yeah, you're quite right. I think we include a case study in today's report on CAMHS waiting lists performance at Forth Valley. And I think, again, Bernie will undoubtedly say more about some of the detail behind that and the importance of agreeing with the point you make about sharing best practice, across NHS boards. I think what we've seen is particularly kind of looking at a kind of a 10.3% change from last year in terms of people. Performance against CAMHS waiting lists. So application of that, as Forth Valley have done, drawing on evidence from elsewhere in the UK and internationally, feels like a significant step forward. I'll bring Bernie in to speak to that point.
Yes, thanks, Auditor General. Just in terms of the waiting time standards, obviously we've reported that only 2 of the 9 have been achieved, and we've also across most of the standards, there's been very limited improvement, small decline against 4, and a small increase against a further 4. But we have seen a notable improvement in the CAM standard, that 10 percentage point increase. And whilst that's still not meeting the standard, you know, this has been an area of work that we've had an interest in for quite a long time. So it's good to see that improvement. In terms of the CAM standard, obviously there's about 8 of the 14 boards are meeting the standard, but there are still some that are lagging. So it does mean that the NHS, the Forth Valley case study, does provide an opportunity for that learning, as you say. Now, referenced within the report that this is based on, they've brought in an international model called the CAPA model, the Choice and Partnership Approach, and that's been tried and tested internationally. And it's really about building capacity within the service. So in Forth Valley, there's been kind of self-assessment within the service against a whole range of criteria. And they've put in place different measures, and that's included kind of workforce development initiatives, so building capacity within staff and skills, and that's included recruiting dedicated CAMHS professionals, but also extending the skill set of the wider team. And there's also been improvements in managing and monitoring demand for the service and the capacity and how that responds to that. So we have seen that marked improvement, and obviously Forth Valley is now achieving the service. And as you say, it's really then about, well, how can this improvement and the approach that's been taken be shared more widely? There's obviously a lot of liaison across boards, but there is also the work of the Centre for Sustainable Delivery, who's really there to help just share improvement and learning and put in place kind of innovative practice.
See if there is obvious good practice which is having a positive impact. What pressure is put on other boards to then follow that example?
I mean, there's a couple of examples that I would maybe draw on, and Lee might want to develop this point, but mentioned a couple of times I suppose ultimately the role of NHS Scotland, the central team within St Andrew's House, you know, has a very developed understanding of how the NHS in Scotland's performing, you know, both the financial position, the operational performance, and acting as a conduit. There are a range of governance structures, you know, accountability mechanisms, support that exists across the NHS. So I don't think there's any shortage of insight that between different boards as to kind of how things are working well. So you mentioned pressure. I suppose it will equally be about grasping the opportunity if one board is performing well, and to apply that in other parts of Scotland. So, so we mentioned the Financial Delivery Unit. There's the Centre for Population Health. There's also the important role that Public Health Scotland plays too, that spans both the NHS and local government in terms of its sponsorship to apply good practice across both health and social care settings. So there's no shortage of structures. I think it's really about helping NHS boards to be able to do the really intense pressure that they're facing today, you know, as we kind of set out in today's report and some of the indicators, but to support that transition to a preventative-based model and delivering against some of the improved outcomes that we're all looking to see.
I'd like to ask you one more question about waiting list times. Earlier on, you talked about England being ahead of Scotland in terms of the over 2 years, bringing down the waiting list for that. Reports are that Scotland's ahead of the rest of the UK in terms of A&E waiting times. Is there a correlation between those two? Is there focus on one bit to the extent that it's causing a delay in the other?
I'm not sure I'm able to give you that level of assurance one way or the other. colleagues might want to come in. I think what we have kind of referenced, I suppose, at paragraph 73 of today's report, that I suppose the A&E standard is an indicator of pressure in the system, Mr Donnan. So, you know, as you'll know in the committee, we're familiar that looking for a performance target of 95% of people to be treated within, treated, seen and admitted or as appropriate within 4 hours. And it's remained around 70% in NHS Scotland. So ultimately, the prioritisation of A&E performance or waiting list times in different parts of the UK will be at the discretion of different jurisdictions. As to whether there's a direct correlation, I suspect is one more for kind of health economists than me, but I will pause just to see if any colleagues wish to offer a view.
Just come in there. So it's a question that we're asked most years, Mr Dornan. We rarely compare NHS Scotland performance indicators with NHS England. The way that the NHS England and NHS Scotland are structured is very different. The way that they measure targets can be very different. There's too many differences and caveats involved for us to robustly compare different performance indicators. I think the overall message that the Auditor General was giving was just about the numbers of people on waiting lists. But of course, what we don't know is what lies underneath that in terms of the way that elective services are delivered or the way that A&E is delivered, which differs between NHS England and NHS Scotland, which is why we tend to not try and compare NHS Scotland with NHS England in our annual reports.
And I wouldn't have attempted to either if it hadn't been brought up earlier on, so I thought maybe there might be some work done there that showed that there was some sort of correlation between the over 2 years and A&E. That was that. I've got one more question, Auditor General. Your report notes that the new outpatient attendances and inpatient admissions have increased steadily over the past 3 years, yet planned activity remains lower than pre-pandemic levels. In your assessment, what factors contribute to this, particularly in relation to specialities like orthopaedics, where waiting lists are the longest, and what steps can be taken to ensure that progress in reducing long waits for treatment is accelerated?
So all you point out, I suppose, is set out at Exhibit 9, Mr Donnan, and then some of the detail underpinning that in the paragraphs that follow. It's complicated, and forgive me for being glib as to the various factors that are driving that. It will be about prioritisation of service. We've also seen, and I'm going to set out in today's report, and again Bernie might want to say a bit more about I suppose partly the medical condition that patients are presenting. People are presenting sicker than they were before the pandemic. COVID remains a factor in the ability to treat people and throughput through hospital. Also, touched on some of the points we've covered to a degree already this morning about turnover and absence levels in hospital. And also, kind of lastly, before turning to Bernie, about the quality of infrastructure. We couldn't cover it in any great detail this morning, but there's an ageing estate within the NHS in Scotland. The ability to maintain that adequately, it becomes more expensive as time goes on. So these will all be the factors that, whilst activity has increased, as we are now 4 years after the start of the pandemic, it will drive some of the rationale as to why we haven't quite recovered. But again, I'll bring Bernie in to get into that in a little bit more depth if she wishes.
Yes, so I mean, basically what we're seeing is, whilst there has been an increase in activity, particularly in terms of the inpatient and day cases, we've seen a 10% rise over the last year. There is still, demand is exceeding that growth in activity, and we've already had that discussion around some of the factors, the complex factors around productivity there. Obviously, the national treatment centres, the delays there and the pause to the further centres is also having an impact in terms of not being able to provide additional capacity that helps to tackle that backlog that's built up. There is a whole range of other activities going on within the, particularly the National Elective Coordination Unit that's doing work around trying to validate, working with boards at a central level to validate waiting lists, and that's really helping to make sure that waiting lists reflect who needs care, and anyone that doesn't need to be on the waiting list can be removed, and then that can free up appointments that can be reallocated elsewhere. And there are some reports of that starting to free up, in the thousands appointments and so on. So I think it's that there's things happening at that kind of granular level in terms of different areas, but clearly it's not having that impact in terms of the kind of more headline indicators, and we're still seeing that growth in waiting lists. So I think it goes back to the point of the transparency, really needing to know what is working, what's starting to have an impact, and what can be scaled up and so on.
Okay, thank you very much for that. Okay, convener, thanks very much, and thank you very much, panel.
Thanks, James. We've just got a few minutes left, but time for, I think, a couple of questions from the Deputy Convener. Again, just to finish off the session, looking at a couple of other aspects of operational performance.
Thank you, Convener. Thank you. James Dornan raised some important issues there. I want to carry on the theme, particularly around A&E, Auditor General. As has just been mentioned by one of your colleagues, we're sitting currently around 70% of the target of being admitted, discharged or transferred for treatment within 4 hours. But we know there's a huge disparity across the country, depending on where you live and which hospital you're taken to, as to how quickly you will be seen. In NHS Forth Valley and Lanarkshire, that figure is as low as 54–55% of target. That's shockingly low. However, for example, Tayside and the Western Isles, it's at 90 and 96% respectively. I can only speak for my own experiences, my local health board, my local hospital, for example, Inverclyde Royal Hospital, where figures are quite stark there. There's been an 8,000% increase in people waiting over 4 hours, and a huge increase in those waiting over 12 hours sitting in A&E. Can I ask if there's any understanding as to why there are such huge regional or health board disparities on NHS A&E waiting times?
Yeah, I think I'll bring colleagues in actually, but I think we recognise the regional variation. We set that out in some of the appendices to today's report. And ultimately, this is referred to as unscheduled care, so that so people who are presenting either in emergency or accident circumstances at a hospital, rather than having gone through a planned approach through primary care services or planned attendance at hospitals. Like, one of the factors that's also relevant is that in terms of A&E, there are also planned attendances at A&E, through engagement with GP. But perhaps and Bernie or Lee might want to say a bit more on this one as well. We look to, I suppose, recognise that the government knows that this is an issue, and looking to under some of the detail of kind of why there is regional variation, why are people presenting at hospital rather than in a planned way, looking at those pathways through what they're referring to as the urgent and unscheduled care collaborative. So I would say there is work underway, Deputy Convener, to better understand, but really kind of primarily get to a point where sharing of good practice amongst different A&E departments, but getting so that patients aren't accessing that as a protocol once they become ill, but rather to have much earlier engagement with primary care services. Again, I'll pause if colleagues wish to develop that.
We haven't looked in detail at those regional variations. Obviously, in terms of pretty much across the board, performance does remain pretty poor, with the odd exception, Western Isles obviously meeting the target and so on. I don't know if Lee's got anything else to add.
In terms of your question about why the variation, I think it's a complex mixture of factors. So as we've already talked about, there are there are different pathways, I guess, that people can take into A&E now. And some of those will be operating, you know, diverting people away from A&E or into planned attendances. Some of those pathways will be operating more effectively and efficiently in some areas compared to others. But again, as we've talked about before in the committee, one of the big things that has an impact on A&E is, of course, the space there is in hospitals to transfer people out of A&E to enable more people to flow through. So, of course, delayed discharges again comes in there as well. And, of course, we do know that there is huge variation in the number of delayed discharges in hospitals across the country. And we know that the Scottish Government are working quite intensively with some boards to try and address delayed discharges. But again, that varies, which will again impact on A&E and the flow through the system.
You segued nicely into my next question on delayed discharge. The report states, I think some quite stark figures, that on average around 1,800 hospital bed days are used up by people who should not be in hospital every single day. That equates to around 666,000 hospital bed days per year, which are used up by people who should not be in hospital. At its peak, that sat at around over 2,000 hospital bed days. Now, that's obviously creating problems. It's creating capacity issues. It's creating issues down the line, but also for the patients themselves. At the end of the day, there's people involved in all of this, sick people. And nobody wants to be in hospital if they don't have to be. And there are people in hospitals who don't have to be, as simple as that. Is there any evidence that the government is tackling the delayed discharge, given that they made a number of very high-profile promises to reduce it or indeed eliminate it? These figures seem to be going absolutely in the wrong direction.
So there's a few various things, and Carol may want to speak in a moment, I suppose, to referencing Exhibit 10. So I think there is a recognition, absolutely, from the government to progress with a range of initiatives to address the totality of what's a really serious issue. You know, I think the numbers are quite stark, Deputy Convener, in terms of the number of daily days, and then the totality of, you know, an extra 666,000 extra hospital days for people who didn't need to be there. There's also regional variation across Scotland. And the only thing I would say, maybe before Carol, as she wishes to kind of speak to the issue, is again just to highlight for the committee, together with the Accounts Commission, it's our intention to undertake some detailed audit work on delayed discharges during 2025, just to track the progress of some of these initiatives, the system-wide factors that are driving delayed discharges, and the government's progress, together with local authorities' intention to address it. So we'll come back to the committee next year on that point. Carol.
Thanks, Auditor General. Yeah, you're right. The improvement we've not seen that yet. And in our report last year, I think we set out quite a range of Scottish Government initiatives to try and tackle delayed discharges. It doesn't look like those will meet their targets. At that point last year, as we've mentioned earlier today, the Centre for Sustainable Delivery, there's the Delayed Discharge and Hospital Occupancy Plan, which was brought out in March 2023, and boards are currently self-assessing against that. The Hospital at Home initiative has been quite successful. It's estimated that around 14,000 individuals were prevented from admission into hospital in a year. However, the funding for that was non-recurring, so Scottish Government funding ended in March this year, and we do know that some boards are stepping back from that approach, which is unfortunate because it did seem to be supporting more people in the home and avoiding hospital admissions. What we can say, there has been some improvement from last year, not in the figures, but in the data that's available to boards. So there are 2 dashboards now that boards can use to help monitor and make decisions around delayed discharges. And the Collaborative Response and Assurance Group has been set up by Scottish Government and COSLA to look at the wider issue of how is social care and acute health, how is that interaction working? And also there's the rapid peer review and response team, which provides practical support to specific boards that are particularly struggling. But you're right to point out that there's more to be done to unpick and understand why there is such regional variation. One might think it's related to population, and as we say in the report, but we then find that Highland, that has a population you would expect it to be a bit lower, is much higher, and then again for Tayside you'd expect that to be high, and it's actually quite low. So we know that Scottish Government are doing a lot to try and understand what the drivers are at the local level, and as the Auditor General mentioned, we'll be starting some work in 2025 to take that forward. But it does have a huge impact on patient flow and hospital occupancy, but it also has a huge impact on people. People that are coming in through A&E and can't be seen in time because they can't be moved to a bed, people that are receiving care in inappropriate places, people who are suffering in hospital because they can't get home because the packages of support or adaptations or whatever is holding up their discharge. That being delayed in hospital is linked to poorer outcomes and certainly much lower levels of experience and satisfaction for people who are stuck in that unfortunate position. So it's a significant issue, and so we're recognising that by doing a piece of specialist or focused work on that next year.
Thank you, Ms. Calder. That's very, very helpful, very insightful. And I agree with much of what you've just said. It's, at the end of the day, there are people involved in this, often people who have been sick or elderly and really just want the best treatment for their families and their loved ones, want them to be looked after in the right place. It seems to me there's a blockage at that end which is causing massive issues earlier down the line, right from the point of A&E all the way through to through care. And that's got to be addressed. Auditor General, there's one page in your report which really struck me the most, and it's page 48, and it's part of Appendix 3. We often get graphs presented in your very helpful reports. And this table, I think, for me, really stood out as the most shocking, and that's the one on not A&E but planned care. And the three main targets which we measure our the success of the NHS by are the outpatient, the inpatient and the planned care treatment times. The targets are 95%, 100% and 90% respectively. Now, that's ambitious and they're high, but not one of those targets are being met. In fact, if you look at the table, the way you present data to us in committee is that we expect to see little green ticks next to any target that's met. On this page, not a single health board in Scotland has a green tick next to it. Not a single health board in Scotland is meeting any of the outpatient or inpatient targets. I mean, that's quite shocking.
I think that table illustrates the scale of pressure and challenge, and in our view, the need for that clear plan, Deputy Convener. That whilst any new investment will no doubt be welcomed by the NHS, I don't think there is enough evidence to suggest that continuing to deliver services in the current way will make that step change and measurable impact that's required. Not just statistics on a page matter, but I suppose it will be the impact of people who are waiting for treatment to get it for today and for years down the line. So, yeah, I think we would recognise the significance of those numbers, absolutely.
How many people do we think have died on an NHS waiting list?
So I don't have that detail, unfortunately.
And the reason I mention it is up until June 2019, your report highlights that there were 250 Scots waiting over 2 years for inpatient treatment. That figure jumped to 7,100. I mean, even just a small percentage of those people waiting and waiting and waiting for treatment might not make it. That's just a piece of statistical analysis one can do. And if you look at that as a percentage of 200, it's hopefully relatively low. If that figure nears 10,000, then you're talking in the hundreds, if not thousands of people. So I guess the point I'm raising is this something that we should be looking at? Is there a piece of work that could be done as to needless mortality in Scotland as a result of horrendously long waiting lists?
I'm sure that would be of interest to many people, especially those who are on waiting lists. But as well as the deeply regrettable people who are who pass away whilst waiting lists, it's also impacting quality of life and for those that are waiting. So it's a very significant issue to be tackled, and as I mentioned, investment will go some way towards that, but ultimately to deliver the Cabinet Secretary's vision for a preventative-based model, translating that to a clear delivery plan is what we recommend as one of the key next steps.
Do we have too many NHS boards in Scotland?
I think that's a structural issue and one of policy for the government to determine as to how it wishes to discharge its responsibilities. So not one for me to comment on.
Okay, thank you. Thanks, Convener.
Okay, right. Thank you very much indeed. And I think at this point I will draw the evidence session to a close. And in doing so, thank very much you, Auditor General, for your evidence that you've given us this morning. Also to Carol Calder, thank you very much indeed. To Lee Johnson and Bernie Milligan, thank you both as well for your input. We've got quite a lot to think about and give consideration to what our next steps might be. But can I thank you very much once again for your time and input this morning. And I will now move the committee into private session.